Jeff asked me to make some comments about surgeon burnout, and it is a big issue in medicine, and it's a little bit of a hot button issue right now. And I think as somebody who I personally feel I've sort of been here and hit that and then bounce back from it, I think I have some stuff to say that may be interesting. I'm not sure. We'll find out. And these are my disclaimers that this is heavily opinion. Um, Maybe nothing here is particularly factual. Some of this is from studies done on surgeon burnout and whatnot. Um, but I will freely admit that this is very heavily my opinion about the topic. So my background for people who don't know me is that I spent 2 years as faculty at USC right out of residency and fellowship. And then basically I moved to Cedars-Sinai in 2003 as a essentially private practice traumatologist. There were no residents there. We had one physician extender intermittently, didn't always have them. And I initially had a partner, but intermittently that was not the situation as well. And then about 8 years ago, they opened a residency program, and so I've been back in kind of more standard academic medicine for the last 8 years. So I think I've got a little bit of experience of kind of being both the semi-private as well as academic world. So what is burnout? And this is from Professor Google. And looking through several articles on it, I found a very interesting way of describing it. And what it is sort of, you can consider a disorder of energy metabolism, but not cellular energy, but just sort of spiritual energy, I guess is a way to put it. And just your energy period. And there are many articles that describe it as a form of basically human battery drain, and introduce this concept of a battery or energy account, right? A bank, and it consists of your physical, emotional, and spiritual charge, and obviously all these things are interconnected, right? Like it's very it's very hard to drain one of these without having an impact on the other two. So this is sort of the basic concept of burnout when you sort of look it up and start poking around the bushes a little bit. Cardinal symptoms: exhaustion, depersonalization, and what is probably most clinically damning for us is a lack of efficacy, and that extends to all levels, not just clinically, but in a lot of different ways. And what are the results? So these are it's a very real thing with very concrete results. One, you tend to see lower patient satisfaction scores with physicians who are burnt out. You tend to see an increase in medical errors. You tend to see people turn their job over, and other issues like substance abuse and physician suicide crop their head up. And physician suicide is another one of these big topics. We've had in orthopedics in particular some very notorious, I guess is kind of the way to put it, physician suicides of late. And a lot of this can be probably at least somewhat loosely related to burnout and symptoms of that. So this is one of the bigger name headlines from the past few years. So what does Google say are the 5 main reasons that we burn out as physicians? One is the practice of clinical medicine. It is a fundamentally stressful job. We are taking care of people, and that's not something that comes without a light burden. The next thing is the actual mechanics of the job itself, especially as a trauma physician personally. Now, as I'm moving up the ranks a little bit, administration, and when you're in private practice, administrating your practice, billing, Those things become big issues and can be high stressors. And hospital politics. We'd all like to think that we've graduated past the high school locker room, but sometimes it seems like we really haven't. Poor life balance. Medicine is, for a lot of us, fundamentally our life. So, and then going back to, for a lot of us, medicine, it's not just our job. I mean, medicine defines most of us on a fundamental level. So it kind of becomes our life. And, that leads to quite frequently poor life balance, which leads to burnout and battery drain. And then, when we're in medical school and we train, we're kind of conditioned to this, right? This is the way we are trained, and this is the way we train people. I mean, I contribute to this system as a physician educator, and we tend to ask a lot of ourselves and of our trainees, and induce a little bit of this. I don't know if superhero is even the right word, but that's the word they gave. But I almost want to put the word martyr in there. And then leadership stressors can be a big one too for physicians, especially if they perceive that they don't have good leadership at whatever level, be it the OR charge and turnover system, your hospital purchasing person, or whomever else. So where does this lead us? So I think about my own practice and my own career arc, and myself in honest recollection. And I think about my early academic years, and you can ask. I have partners that remember me as a junior attending, because they were young junior residents at USC at the time. And they'll freely tell people I was an absolute terror as a junior attending. And I kind of see that a little bit in some of my junior partners. They chew on the residents a little bit harder, I think, than the older staff. And then we went into the private practice years, and a good chunk of that I didn't have a partner, and I was actually stuck alone, and I was working way too much, and I kind of really fit a lot of these things, right? I had a very stressful, busy clinical practice. The job was everything and was wearing me down, and I had incredibly poor life balance. My job as a level 1 orthopedic traumatologist was my life. What did this lead to? Probably big contributor to my divorce, among other things. And now I've kind of hit my second half of my career and back into academic practice. And at least I like to think I've figured some of these things out and changed parts of my life around. And I think I'm happier. At least I perceive myself as being happier. So maybe I'm wrong. What have I learned over 20 plus years? One, no person is an island. Medicine is a job that is incredibly difficult to do alone. And I'm not sure that anybody who's running around solo actually truly does as good of a job as they can do. And if we're not doing the best job that we can possibly do as doctors, we're probably doing our patients a disservice. So I think good partners are 1000% critical. These guys were my early partners and lifesavers, to be honest, when I was practicing in private practice. So the other thing I learned, it's definitely okay to say no. You can't do everything all the time. And this isn't just talking about consults and seeing patients. This is everything else. You can't give every talk. You can't go to every meeting. You can't do everything of anything. And so you got to learn to say no, which is a big thing that we're not taught, I don't think, very well in our medical training. In fact, it's one of the antitheses of things we're taught. We're taught to never say no. But I think that's a big thing. You got to learn to say no. And then finally, you got to have a hobby, and it doesn't have to be necessarily some sort of physical pursuit, but you got to have something that occupies your time that has nothing to do with medicine. That's just my opinion. And I think a lot of people I know who have gotten their second wind and through burnout phases and stuff, I think would echo this. You got to have something else. It can't just all be orthopedics 24/7. You got to have something else that you can just turn it off and go on to. And finally, your family. That's the big thing. And I think Don Wiss gives a great talk on time allocation and being a doctor. And he said, I think what he says specifically is there's no such thing as not enough time. It's just a matter of where your priorities are. So you gotta always remember who you need to prioritize in your life. So this is what I think about physician burnout and being happy as an orthopedic trauma surgeon. Like I said, I don't think that a lot of this stuff is particularly factual. It is heavily my opinion, but I will tell you that I was definitely there. If you met me in 2007, 2008, 2009, you saw somebody who was, working himself to the nub and probably had a lot of behavior patterns that weren't particularly fantastic. And I think, learned a few things over the years, and I can tell you right now, I am actually very happy with where I am right now. So with that, I will end this and open the floor to questions.
So Chuck, I'll add a bit of a comment that I would say I've known you through all these years, and I've always felt you were an outstanding person, and I'm not trying to toot your horn. So certainly in my environment and space, and I think that sometimes the issue of either good partners or good friends and colleagues that definitely allows us to be kind of at our best. It doesn't mean that we feel or behave that way 24/7, but it's certainly my perception of all my interactions with you in the past.
Much appreciated. Much appreciated.
So and I'll certainly open this to anyone else on our panel that wants to ask you a question. I'll pause for a minute if anyone wants to speak up.
Chuck, this is Greg. I would say an N of 2. It's not all just your experience, it's my experience too. And I would say it's amazing how parallel our careers have been. I'm also in a much better place than I was 10 years ago. I would say the difference for me was I tried to be a great guy at work and treat the residents well. And the downside was I brought home the bad behavior. And that's where I decompressed. And so, yeah, it's more than just your experience. I think you're right. You're spot on.
There's a question from Emil or email. Forgive me, I don't know how to pronounce that, but asked, what's the best way to kind of figure out your limit and learn when to say no? And I think that's just one of those human nature things where I'm not really sure we can have a single best way. Personally, I think I discovered it by going too far and then beginning to come back and working my way backwards. Eventually you end up saying no because you literally can't do it. You simply cannot do something. And then I think saying that and breaking that barrier kind of lets you, and then realizing, hey, that actually felt kind of good. I'm happy I'm not dealing with that. I think it lets you kind of begin to reset your internal barriers or hurdles to saying no. So,
other questions from our panel?
Yeah, so Charles, I enjoyed your lecture, and I echo what Jeff said. You've always been very professional. I've always enjoyed our interactions, and thank you for being so candid with your comments. The question I had is along those lines, but a little different. Is that so? A lot of young faculty members now, or our junior partners, they or people that we train, they actually drink this or are part believe in that work-life balance better than we ever did and better than we all still do. And the challenge that I have seen locally and nationally in a lot of places is that they struggle actually more in the operating room with their surgical skills because they don't have the Malcolm Gladwell 10,000 hours in. And so how do you actually get, how do you think that for the next generation, the younger people are going to be able to be proficient in our skill set, right? While still doing the things that we're talking about.
And I think, Raja, that's the orthopedic and not just orthopedic, surgical educators $1 million question right now, right? Because we are running into that issue where exactly what you're talking about, where, we have, work hour restrictions, et cetera. And the residents simply aren't, clocking the number of cases and the amount of surgical exposure that we probably did in the past in general. And I think there's not an easy solution to, I don't know what the solution is to that. I know some of this is, some of your efforts, for instance, to create very documentable, objective sort of skill set, like, okay, show me that you can do this. Okay, we've documented that you can do this. But I don't know. I mean, because
well, the reason was that, and we'll get into
right.
that. It's more the question I'm asking you, like one of my former residents who is now a fellow in another part of the country, and he himself has sacrificed a fair amount. And he's a traumatologist. He's a trauma fellowship. He's sacrificed so much to get to where he is that he doesn't have a professional life because he doesn't want to be anyone of like his peers. And I try to tell him, like, it's okay to pull back a little bit, and but the challenge is that when people do pull back, they don't get the reps. And so I don't. You're right. It is a question. It's just, what advice do you give your chief residents right now?
I think a little bit of it has led to is contributing to this over super specialization we kind of see in orthopedics in general. And I think one of the compensatory things, and I don't know if it's a good or a bad thing, but what I'm seeing is that, instead of everyone getting X number of reps in here, what they're doing is the number of reps is here, but they're shifting it so that I'm going into foot and I'm going to concentrate my reps on foot, and I don't know that this is a good thing, but it seems to be at least one of the compensatory mechanisms. But it's certainly going to accelerate the death of the general orthopedist, which may be dead already. I don't know, but
That makes sense. Do you think there's an appetite, and this is for all the panels, do you think there's an appetite or the possibility of extending surgical residencies from 5 years to 6 or 7? So they get the reps?
I don't know that the appetite is there, but the problem is that the necessity may be there. I mean, look at the UK training system, right? It's not really a defined time frame, right? I think I could be wrong, but Canada, sometimes people can get stuck kind of on the treadmill a little bit, right? Waiting for jobs to open up and whatnot. So, I mean, we may end up having to change the way surgical training goes forward. But like I said, this is the event horizon coming up, and how are we going to confront this? I'm not sure.
So
I worked in New Zealand for a while, and it was 10 years to train an orthopedic surgeon in New Zealand. Usually, they usually spent 2 years as a junior house officer, then up to 2 or 3 years as a junior registrar, and then it was a 5-year orthopedic residency. So, and then they did multiple fellowships.
Yeah, and so I wonder, I mean, this is part of the complexity of the issue, and it's a really spectacular conversation. I don't, I've tended not to give advice, but I do tell people that there's a trade-off, and that, I'm able to look back on my career and not have a tremendous amount of regret, because if I didn't have those repetitions, I wouldn't have gotten to the level that I was at. Then I think once you achieve a level of proficiency, not necessarily expert, I don't think actually that many orthopedic surgeons get the 10,000 cycles into the probably 100, maybe 150 skills that we need to be expert at. And so we probably get expert level in a few, and proficient level in others, and competency level in a few others. But I do think that with the training, they're getting less and less reps of all that. So there's a trade-off. And I think that there are still some people going through training that are hoping that they have the ability to be intense in their getting into the career and putting in a lot more reps. And then with the hope that once they get to that point, that won't necessarily be a lifelong endeavor like some of us who have preceded them. Great points, though. Any other questions or comments? Chuck, any last things that you want to say?
There was a question brought up in the Q&A on like the relationship or the comparison maybe vis-a-vis the 9-to-5 quote unquote healthcare worker versus the physician who can kind of control their hours to some extent. And I think, the physician always has a certain amount of inherent power that I think enables them to maybe cope a little bit more, despite usually typically not clocking quote regular hours. But I think in the end, fundamentally, healthcare, the providing of healthcare is a fundamentally stressful job. And whether or not you're a shift worker and able to just leave it alone, and when you go home, or you're a physician that frequently can't really leave it alone, I think we're all prone to burnout issues because it's just a fundamentally stressful job.